Good afternoon to everyone who's joining for the session, and thank you so much for joining us today for today's webinar on From 1 to 100, Unpacking India's Digital Health Evolution through the 100 Microsites Project, a special initiative by Youth Charcha, which is an online forum hosting webinars with leaders, entrepreneurs, and young professionals in the digital health space, fostering open conversations on the latest developments and future actions. I am Pallavi Jain, and I am leading the youth initiative at PATH. Many of you who've joined in today are already members of PATH, of the youth community. But for those of you who are new, youth stands for Youth Ownership of Digital Health, and it's a community of young digital health professionals across the world who are under the age of 35. Our vision is to empower young professionals in the digital health sector to become future leaders in this space by providing them with increased representation, knowledge, and networks. Currently, we are a community of close to 1,000 members across 34 countries. If you want to become a member of Youth and be a part of wonderful events and resources that we offer, we'll soon drop a link on the chat and you can become a member. It's free membership. And you can also download our app for quick updates. So today we will be discussing the role of the 100 Microsites project in the larger ABDM initiative, and we'll hear from our experts on their on-ground learnings and experience. Today we are joined by three distinguished speakers who are experts in their field. We first have with us Veda Halve, who is a program officer in the digital health vertical at PATH. She is leading the implementation of the ABDM 100 Microsites project, where PATH is supporting 61 microsites in 10 states. Welcome, Veda, and thank you so much for joining us. We also have with us today Dr. Pallavi Gangil, who is a healthcare and digital health transformation specialist at Piramal Swasthya. She has over 15 years of diverse experience spanning clinical practice, healthcare management, and 4+ years exclusively in digital health consulting. She has played a pivotal role in advancing the ABDM initiative through multi-state implementations. We also have with us Vikas Upadhyay, who is a senior project associate at the International Innovation Corps. He has been driving the digital health transformation in Uttar Pradesh for the past 2 years. He has helped the state digital health mission strategize and implement the private adoption of ABDM across the state and build the digital capacity of the health cadres in the state. Vikas is passionate about leveraging technology and data to enhance policy execution and improve service delivery to the last mile populations. Welcome to all our guests, and thank you so much for taking out the time and talking to the youth community today. Today's webinar will be moderated by our very own Yodha, Dr. Saurabh Ingole, who is a program associate in the digital health vertical at PATH. He is a public health professional with over 4 years of experience, 3 years of which are in the digital health domain. During his tenure at the National Health Authority, he played a pivotal role in the ABDM 100 Microsite project and the Unified Health Interface, driving adoption and contributing to India's digital health transformation. Currently at PATH, he continues to drive strategic health interventions, facilitating state and central collaborations for the ABDM adoption. Saurabh also serves as a core committee member of Youth and is a very integral member of our community. To all our audiences, thank you once again for joining in. In case you may have any questions through the webinar, please feel free to drop them in the chat and we'll try to take them as many as possible towards the end of the webinar. And also, this session is being recorded. Thank you so much. Saurabh, over to you.
Thank you, Pallavi. And your team for bringing this session to our audience, where they can learn about our nation's digital health ecosystem, that is ABDM, and the efforts that are being done to achieve the healthcare digitization. I once again welcome all the panelists, and it is great to have you here all today. I would also like to welcome all the participants who have joined us here today. Before we dive deeper, let me take you through a brief journey of how digital health initiatives have evolved in India and how ABDM came to existence. India's digital health journey began in the early 2000s with the ICT adoption in healthcare. Initiatives like National Rural Health Mission and digital tracking systems laid the foundation for the digitization of healthcare in India. Digital India Mission of 2015 and the National Health Policy in 2017 further emphasized digital health, leading to integrated health information platform which gave real-time disease surveillance data. The turning point came in 2019 with National Digital Health Blueprint, which paved the way for the National Digital Health Mission, which later got rebranded as Ayushman Bharat Digital Mission, or ABDM as we know, in 2021. ABDM introduced key digital building blocks like ABHA, HFR, HPR to create an integrated ecosystem. Today, efforts majorly focus on interoperability, data privacy, and targeted adoption projects. Today, we will learn more about one such project, that is 100 Microsites Project Initiative, which is a targeted adoption project, an initiative of ABDM. So to begin with, Veda, could you briefly explain to our audience the concept and the objectives of this 100 Microsite project?
Okay, thanks, Saurabh, for moderating this session, and thanks to the Yo team for having us for this session to share our insights and experiences. To answer your question about the concepts and objectives of 100 Microsites project, I think we'd have to go back to 2021 when ABDM started. And for the benefit of our listeners who might be uninitiated, the Ayushman Bharat Digital Mission was started with the vision of creating an ecosystem with relevant healthcare sector stakeholders and to connect them through digital means, through digital highways, so to speak. And it was implemented through state governments in the states. And of course, it being a government program, a government mission, it was first rolled out in the public sector. Over a period's time, it was seen that the components that Saurabh also mentioned, the facility and professional registries, the ABHAs, those are the Ayushman Bharat health accounts for the citizens, and the ABHA linked electronic health records, they were primarily coming from the government sector, the public sector. But we all know that private sector is actually a very important contributor to the healthcare sector in our country. A majority of our population depends on the private sector. And within the private sector also, the people are not directly going to the secondary or tertiary hospitals for their treatments. They first approach the smaller clinics or nursing homes, their local pharmacies, their local labs. Right. So it was immediately understood that there is a need for involvement of the private sector in ABDM if we are to achieve that vision of creating that ecosystem. That ecosystem involves everybody from top to bottom, central government, state government, public, private sector professionals, facilities, partners, and everyone else, right? So, to kind of bring in the private sector into the ABDM, a pilot study was conducted in Mumbai, Ahmedabad, and Surat, where a structure, an approach framework was tested out, where the targeted intervention, like Saurabh mentioned, was uh, conducted. What happened here is that officers, communication officers, were sent out on the field to talk on a one-on-one basis with the professionals in facilities that were in smaller bastis, in facilities that were 0 to 30 beds, and they were counseled upon the benefits of digitization and on ABDM. They were given demonstrations of the various softwares and solutions that were available in the market that could help their not just the businesses but their clinical practice as well. Capacities were built on the staff, and the different components like ABHA and ABHA linked EHR were introduced to them. The reaction, the feedback that was gotten out of this entire pilot was so encouraging because the private sector was waiting for something like this to come up, something credible, something from the government to come in. And so that motivation kind of led to the scale up of this targeted intervention into the 100 Microsites project. The concept of the 100 Microsite project is basically the targeted approach to the private sector to get them involved in the ecosystem, have them digitize their facilities, have them build their capabilities for delivering healthcare through digital means, and to participate in the ecosystem in a very meaningful manner. The objective is ultimately to create this interconnected and interoperable ecosystem where the patient is at the center of it. The patient is at the center of the ABDM mission itself, right? So the patient going from one facility to another can have a seamless movement through digital means. So that is broadly the objective of the 100 Microsites project. As of now, there are 121 microsites active in 19 states and UTs, and it is going in a full-fledged manner. We have been in this project for over a year, and there's no end in sight. There's only uphill from here.
Uh, Thank you, Veda. I think, as rightly mentioned by you, the Mumbai pilot and the other pilot, the Gujarat pilot was came from a thought that it is quite important to involve the private healthcare sector into the ABDM system. As the statistics also say that 65% of the India's healthcare infra comes from private, while which is contributed by over 8 lakh facilities, which almost comprises to 70% of the total healthcare spends in India. And thank you for giving us a brief intro and the background about the concept and the objectives of the 100 Microsite project as well. Okay. Now building on to that, Vikas, could you briefly walk us through how the microsite model is structured and how it is implemented?
Right. Uh, First of all, thanks a lot to Yod community for having this session. I think this session was in much need because we have already done more than 100 pilots of microsites in our country. And thanks, Saurabh, for giving the question. I would like to extend the same point that Veda mentioned about how microsite helps the private ecosystem to get under ABDM umbrella. And if we see the structure, I think the microsite structure, the guideline of microsite is built in such a way that it has a very federal structure, because at the central level we have the National Health Authority, which is like a guiding body which has created the policy of microsite, and which then translates to the state level. And at the state level, we have again multiple bodies which are handling this. The very important, the most important body is the State Digital Health Mission, which is like the decision maker and the authority at the state level for any implementation happening in the state. And because state is a health subject, the role of the state ABDM team or the state government becomes even more important in microsite implementation, as we have seen in many states. Uh, I'll mention the development partners at the end. But when we look at from a perspective of implementation, we have the first point of contact with the private healthcare are the interface agencies, which are kind of implementing agencies at the grassroots. So interface agencies are those NGOs or non-profit organizations which are already working on implementing the health programs at the district level. And these are the people who actually go to private professionals and meet them and build their awareness and build their capacity to onboard onto the ABDM system. Uh, so the starting from the private healthcare professionals, and to the interface agencies, and then guiding authorities like the state government, and then the policy level authorities like the National Health Mission. I think the system has been made very in a federal manner, and it's a very structured implementation process to implement microsites. I think the center of at the fulcrum of all these actors comes the role of development partners, who have been like bridging all these ecosystem actors together, because development partners have been coordinating with the National Health Authority as well as the state government, as well as building the capacity and hand holding of the interface agencies, to even going to the private professionals and understanding their concerns. So I think the microsite model in itself has been made in such a way that at every stage there is a guiding body, and we have all the actors working together for the implementation of private adoption within the private healthcare. So yeah, I mean, I had a very great experience when I was coordinating at the same time with so many different actors for one implementation. So yeah.
Thanks a lot, Vikas. As explained by you, the model seems very well structured and thought of by keeping all the relevant stakeholders into consideration. I also thank you to emphasize on the role that we development partners have been doing and contributing for this project over past years. I also believe that this project has very smartly leveraged the trust that the PPSA agencies have garnered over the years via the NTP and G 2.0 programs. So I think that also played a important role in gaining the trust of the professionals and getting them on board to the ABDM ecosystem. Okay, also having understood the concept and role of this project, I would request Pallavi to take us through the thought and understanding that why this project is critical and how it can lead to better ABDM adoption.
Sure, Saurabh. Thanks for having me here. Thank you to the Yoda team and thanks for the question. So I feel that microsite program is a catalyst for whole ABDM adoption because having policies and operational frameworks that is essential and that are there. But what is happening on the ground? That feedback, that learning, we were only able to capture through the microsite program. Also, many times large hospitals, they are having their own digital systems and they are operating on that model for so long, but it is the small clinics or the pharmacies or the labs that are left behind. And when we talk about creating a digital ecosystem, by that we means creating a interoperable digital ecosystem. So as rightly mentioned by Veda also in the start, that private healthcare sector holds the majority of equity in this service delivery. It is 60 to 70% of the practice is private in India, and leaving them behind is not a good option for us to have a vision like interoperability at the large scale in the nation. So this program not only gave us the real live demonstration sites on the field, but also we were able to handle the ground level challenges that small practitioners or pharmacies or labs are facing at that time. So sometimes when we were in the field, we witnessed that the doctors already know, or the healthcare professionals already know about the ABDM program, being a small practitioner or a standalone clinic, but they do not know how to enroll in the system, how this registration process works. So this program made us to give them a hands-on or a one-to-one approach to interact with them, learn from their experiences, what they think about the program. So this is also gave us the kind of mechanism to give feedback to state level officials as well as to National Health Authority. Also, we make them navigate to through the challenges of which HMIS software is suitable for me. We try to give them demos, try to act as a bridge between the software providers, as well as there are so many players in the market to choose from. Microsite program help us make them help us to create a bridge between all of them, and to set a clear communication channels, and the coordination is sorted, and that's how they will find it easier to onboard on the process. Also, there are a big lag of the verified as well as non-verified professionals and facilities on the dashboard. With the help of microsite program, we were able to navigate that challenge as well. With the help of this program, we are reaching more to the councils as well as other verification facility authorities, and trying them to get us on board on this vision, why this having a single source of truth for the registries is necessary, what it will be beneficial for the citizens in the long run. So also there are many factors that are stopping the doctors to come on this program, like the fear of data security. They think that this program is not for me, this is for something else. Sometimes they are in the program, but they know they was not able to know the whole benefit of this program, what this is offering them, what is on the table for them. DHIS is one thing that turns out to be a great incentive for driving this adoption, but we witnessed several clinics that are doing very well with ABDM implementation, generating records, linking them, but they were not aware about this incentive. So once we tell them about this incentive, get them on board with DHIS, then they were able to get rewarded for their efforts also. Also, many times small practitioner crave for a recognition or some sort of acknowledgement from the from officials or from the society. So this platform also gave them that recognition. We recently have a good clots program at NHA, and we got very positive feedback from the ground. The doctors were very appreciating for that. So I think overall, to kickstart the adoption on a smaller level and to understand what is stopping the doctors to come on board, or the facilities, it was a good program to start with.
Thanks, Pallavi. And it's great that you mentioned that this project is not only bringing in the adoption, but it is going to the last mile where the actual healthcare delivery is being delivered, and there is a need of digitization wherever, to the last mile, to the villages, to the small and single doctor clinics. And while collecting the feedback and improving the system, we are also generating awareness amongst the healthcare professionals and the healthcare facilities and the faculties, how important it is to be on the ABDM ecosystem and provide an integrated care, which also benefits the patient. And the efforts have been translated into numbers as well. Since the inception, the project has added over more than 50,000 healthcare professionals, more than 49,000 healthcare facilities. And I think we just translated to contributing over 50 lakh ABHA linked EHRs. Now, understanding the importance of the project as explained very nicely by Pallavi and the huge adoption it has added, I'm sure that the audience would be keen to understand how it is done, what is the strategy behind this. So my question to Vikas is that what has been the strategic approach in rolling out these microsites?
Yeah, thanks, Saurav. I think it's a very important question because talking about taking the example of UP, where I've been working on the adoption, and we worked since the very start of the private adoption part. So I think in the very start, the idea was to come up with a implementation plan. So if you remember, said you were also there when we were planning that out with, because relatively private adoption is a very new venture in the digital health space, and it's an evolving ecosystem, the digital health ecosystem. So the first, as I recall, all those times when we started back in 2024 January, all those plannings with the State Digital Health Mission and with all the partners. I think the very first idea, the very first approach was to collaborate with all the partners and with all the ecosystem players that I mentioned in my previous question. So collaboration has been, I think, collaborative approach to strategizing has been the heart of this program. Because talking specifically about UP, there were 35 districts where this pilot was implemented, and all of these districts were divided into four partners, right? And we could not have a strategy working in silos in different districts. Like for example, Path had 16 microsites with them, and likewise we had different numbers of microsites. And the idea was very clear to have a strategy, to have a common approach to the implementation of the private adoption. So I think the strategy was to collaborate. Firstly, the first point of collaboration was to find out the number of facilities and in these 35 districts. So I think finding out the baseline was the first strategy. After, I think, when we had that through background research, when we had that number, the second step was to train these interface agency people, because when you go to the professional, it's very easy to approach them and make them understand, but you need to train these interface agencies, these bunch of 6-8 people that will go to the health professionals and build their awareness. And for that, they have to be very confident about their knowledge about ABDM and the whole process itself. So I think the second strategy was to train these interface agency members who are working on ground. And for that, we did a need-based approach. We started off with the basics, and we connected. And also another very important part was to follow up on the process. Like every week we used to have, I think all the partners followed this process, that we kept the communication channel very clear with these interface agencies and with all the other actors, with the development partners. So after the training, I think one important approach in the whole process of implementation was also to exchange the knowledge, because in the pilot of 35 microsites, and or for that matter 100 plus microsites, we have a lot of knowledge incoming from the ground. And it was very important to exchange that knowledge with all the partners, so that we are able to solve the issues with the existing knowledge which is there in the ecosystem. The only catch was how to exchange that knowledge. And I think we did a pretty good job by exchanging that knowledge from time to time. That helped, solve most of the challenges on ground. Also, one of the important strategy, I think, was to how to engage with the private professionals who are the key points to uptake of the adoption. And I think in that sense, specifically in UP, the district chief medical officer's role came to be very important because they helped us connect with the associations, uh, which then translated into nudging the health professionals on ground. So I think we have in the whole strategy of microsite implementation has been to use the knowledge which is there in the ecosystem, exchange the knowledge, and solve the issues which are coming in the implementation. And again, I think this part of knowledge that we have gathered through the pilots, I think we'll be able to use it, in the coming next phases of private adoption.
Thank you, Vikas. I think the strategy seems very straightforward. It starts with collaboration, capacity building, robust monitoring evaluation, follow up, and then doubling down on the same things till we get the results. Yeah, thanks for defining and explaining the strategic approach of this project. Now, since Path has also been working in diverse geography across the country, so Veda, based on your experience, how have the approaches varied across different states and what unique insights have emerged based on their geography?
Okay, so PATH is currently supporting 10 states. And of course, every state has come with its own set of experiences and learnings. Uh, but what we found was when we started approaching these states, we found that some of the states were actually quite advanced in their digitization journey. Some of them already had some digital initiatives going on, working quite successfully, and some of them were new to the concept, but there was still enthusiasm on taking something up and implementing in their states. What was the one thing that was common across all the states was wherever we got keen support from the state authorities, district authorities in implementation process, in monitoring and evaluation of the progress in outreach, that is where the results are fantastic. What we know from any initiative that is introduced for the public is that there is an adoption curve. We know that on an individual level for a new initiative there is always some level of doubt, some level of skepticism, and when we were starting out we were getting all sorts of questions from everywhere. What about privacy of data? How do we secure the data? Many professionals have had different kinds of questions, but the involvement, the endorsement of the top leadership, the communication that the state governments and the district authorities had with the associations and councils in reassuring and clearing their doubts on the data privacy. There was communication through printed material and through meetings where it was made amply clear that data is not getting stored anywhere. Nobody is able to view the data. It is protected under DPDP Act. All the protocols, it is privacy by design that was in place. So all of these answers that were given, all of this endorsement that came from the top leadership to the bottom, that is what helped us actually roll on to progress quite fast. That is the one thing that was common. I don't suppose there was much of a difference in the geographies because ultimately the private sector, like I mentioned earlier, also has a huge appetite for innovation, right? They are looking for technology, they are looking for ways to improve their businesses and their clinical practice. They want to have something legitimate coming in that will help them. So this ABDM, the mission, the objectives of the mission, what offerings it had for the professionals and the patients alike, that was interesting to them. But amongst all geographies, what remained common was the endorsement from the top to bottom, and that is what served our purpose, and it is what will keep the momentum going forward as well. That's what I feel.
Sweta, for setting up the context and explaining that no matter the geography, if there is a better involvement from the state and the higher authorities, and how transparently the information is being delivered from top to bottom, and then again how the feedback is being taken from bottom to top. I think if that is clear, then the strategy and then the geography doesn't affect much. And yes, there might be different stakeholders, but as you mentioned correctly, the private sector has been hungry for innovation. The participation has, as we mentioned earlier, the adoption statistics have gone quite well via this project. And not only this, via this project, we are also clearing various doubts that the healthcare professionals might have, and they do not get chance to get those doubts cleared very quickly. But I think via this project, how we are going door to door to the single doctor clinics and the facilities, I think this is quite this is also capacity building, building the capacity for digitization and the digital age that is coming ahead in healthcare. Okay, thank you. As explained in the model and strategy of the project, and as mentioned in this answer by Veda as well, various stakeholders are part of this project. So I would like to ask Pallavi, in your experience, which stakeholder groups have been the most critical for successfully implementing this program, and how were they engaged?
Yeah. Okay. Thanks for the question again, Saurabh. So I think so success of 100 microsite program totally depends on the strategic collaboration or the collaborative approach from all the stakeholders. I think it is very difficult, or I think it is not right to say which one is important and which one is not. But I try to layer them as what we felt on ground. So first and foremost, I always want to put state officials at the top layer, because we think that state government is responsible for implementing on the for doing implementations or initiatives at the for national health programs, or for the for state health programs, or for the government hospitals. But it is not true. As we all witnessed on the ground, their role is very well placed in the private sector adoption also. Very several times we need their support, and sometime letter or sometime nudges to the councils and associations and the other agencies to support us. So the state being on the top and how we engage them. So one thing is they have their own priorities, and our role as a DP was to make them aware that this program is also important, and this is what we are signed for the future. ABDM is not a 1 year, 2 year program. It's for a long run here. And why it is why it is important to have the digital ecosystem in the, like we have in other sectors, like financial sectors and other sectors, giving the sometimes the success stories of other sector, how digitalization help the citizen. Maybe citizen level benefits are not realized yet, but that is not the case that it will not become visible to everyone in very shortly. So first layer is state officials, so doing their capacity building, make them aware about the things that are happening at the NHA level, sometimes to create a communication channel between state and NHA, and as well as to seek their support also when we are stuck somewhere or we faced a roadblock, sometime to the associations and councils and all. Second layer is, although citizen is the core beneficiary of this program, but it is also important to place healthcare providers and other labs and pharmacies labs and pharmacies, there are health professionals in those places also at the second layer, because they are not the core beneficiary, but they are the most critical layer of this program. Because having a program is one thing, and make people use that program is a different thing, and it is totally important for making that program successful. Otherwise, having ABDM and healthcare providers not using that system, it is completely making no sense here. So I mentioned before also, one-on-one approach for their onboarding is one thing that we or every development partner as well as interfacing agencies did, and lots of capacity building sessions, lots of hand holding, navigating through their fears, making them to understand this process, tell them which one is the best solution for them to use. And also we got lucky that in our 3 states where we are doing microsites, we got several doctors that are naturally motivated towards adopting the digital health ecosystem. So making the ABDM champions out of them, and then making them as a champion and showcasing them in their peer group to get more traction and more support that we did, and that worked well with the healthcare professional. Another layer I want to place the healthcare tech solution providers, because without their technology or without that solution, the thing that we are trying to achieve will not happen. So sometime helping them to get connected with the doctors, or sometime to get connected with the state officials or the state PMU JDs and all, and also sometimes helping them with the integration part also. This part is important, and this is how you can make your solution more citizen or doctor friendly, and this is how you can customize it for a doctor to adopt well. So these kind of feedback also we try to give them, and they were very well received by the healthcare provider also. Last, I want to place councils and other verification authorities, because without their support it is not possible to get the result that we want to achieve. Doctor is registered, but when even when it is registered on the ecosystem and it is not verified, that make no sense. So we need verifiers at all the level. So this is how I want to place all 4 authorities.
Thanks, Pallavi, and thanks again for emphasizing the importance of stakeholders at different levels of the project. As I think mentioned quite nicely by Vikas as well, that the first step is the collaboration, and I think without collaboration and at a different level of this project, how the project is implemented, I think different stakeholders play a crucial role, and there needs to be a collaboration between all of them for having an overall success of the project. And I think, as mentioned very correctly by Veda as well, the state again lies at the top of it, because state health is a state's issue, and then they take it up how it needs to be done, and they facilitate the collaboration ahead as well. But again, Veda, given there are different healthcare landscape across the states, and also there are different approaches and the expectation of the state as well. So during the implementation of this project, how did you make sure that there is a flexibility and adaptability in your approach?
Okay. So how I understand this question is that India has a diverse healthcare landscape, in that we have a variety of different kinds of service delivery people that are available, options that are available. So in the healthcare sector in India, we have a thriving modern medicine practice, of course, but we also have Ayush practitioners, we have dentists, we have nursing professionals, we have allied health professionals, and somebody in the comments is also asking about how the digital tools were, adapted or changed, or however, modified for their benefit. So the flexibility and adaptability, like Vikas also mentioned, was ensured through that feedback loop that Pallavi was talking about. The first thing that we did when we went on ground, we went with, of course, the basic level information about ABDM that we had, the main components that we communicated, the major benefits that were there. But initially, after the doubts cleared, after people started, understanding what ABDM was, what digitization was, what softwares could do for them, they started thinking from a more evolved sense of what can this software now do for me, for my practice. Now, in the healthcare ecosystem that we're trying to create, we have doctors, but we have pharmacists also, we have labs also. So the things that we talk to the doctors about is not the same that we can talk to the pharmacists about or the labs about, right? ABDM offers some different sets of value propositions for all of them, and that is how we communicate to them. The training and retraining that Vikas was talking about, encompasses especially this, that every time you go to a new stakeholder, your communication strategy has to change from what on the basis of what they want, right? So even between two doctors, one doctor might want some kind of a scheduling feature in their software which helps them in their business practice, but some other doctor might want some predictive analysis that helps them track the records of long-term patients. There have been, demands for some specialized tools for ophthalmology practice or a gynecology practice or something like that. We are in on the benefit of the fact that NHA is not just an apex body but also as equal a partner in this entire project as us, a technical partner, and we have the digital solution companies as well. So the real time feedback that we get from the ground, every individual professional is directly communicated to them, and the digital solution partners that are there, they try to modify their solutions according to the market's needs. So that is one way on how we address the flexibility issue from the tech part. The communication, I also mentioned that the value propositions change every time you go to a new stakeholder. So that is how the communication strategy changes. And as we move forward, as more stakeholders join in, the communication will keep evolving with it. We are just at the beginning of it. Once people start actually using it, the way that we talk to the citizens about it will also change over time. What all ABDM has to offer is yet to be seen, because right now we're only creating that foundation on which the ecosystem will ultimately stand. So the feedback loop is the backbone, so to speak, of the adaptability part.
Yeah, thanks, Sweta. I think feedback loop and continuous monitoring and evaluation of your microsites. What are the expectation of the end user, be that the digital health solution company or the healthcare professional, or in many cases might be the state as well. So I think since again this project has been an inception of such targeted efforts in digital health field, I'm sure our audience will also will now have gathered insights on how even having some set of standard operating procedures, we require adaptability in the approach and the value proposition that we need to pitch based on the type of healthcare professional and the landscape that we are dealing with. Thanks for informing us with that, Veda. Coming from adaptability of the project, certainly there are various challenges that are identified as we move along with the implementation of the project. So I would like to ask Vikas, what were some of the major challenges that were encountered during the whole implementation process, and how were they tackled eventually?
Hi, yes, Saurabh. Thanks a lot for that question. I think uh, i- any implementation project has, numerous challenges throughout the course of implementation, right? And so, as I already mentioned, and I think Pallavi and Veda have also mentioned some of the challenges, but I'll try to, encapsulate it in some, and I would love to hear from them also, because, all of us had different set of challenges at different points of time in the implementation process. But I think, as far as I remember, the we started with a very basic challenge of, what I mentioned in the beginning. What is the universe of facilities, private facilities we are looking at? So that was the very first challenge, how to start. And for that, I think all of us did an exercise of finding out, the baseline data of the facilities on the basis of NHRR and Clinical Establishment Act data that were there. So I think in terms of starting off, the major challenge was to find out the universe first. Now, coming to the implementation itself, I think throughout the course of microsite adoption, we have had different kinds of challenges. For example, technical issues that were cropping up every day. Whether it's about the portal, the National Health Registry portal was also changed. Previously, there were two portals for HFR and health professionals and health facilities registration, but later on they were merged. So, in terms of technical issues, there were regular issues that were coming on the microsite dashboard, on the registration part, as well as the health record linking part with ABHA. So, I think technical issues were something that was a part of implementation throughout the process that all of us, I think, invested the most in, because we had to be connected with the state, with the National Health Authority, with the HMIS partners to solve these issues. And since the interface agency has been working very hard on the ground, we had to resolve these challenge in the very short period of time. The turnaround time was very less in terms of the technical issues that were there. I think one very big implementation hurdle was the HPR verification, verification of the health professional register. And for that, I think all partners and all the state governments have been in touch with the councils, because there is clearly a distance between the council and the state and the national authority, national health system, which is there. So I think we tried to solve all the verification issue by establishing a communication channel with the different councils, be it the modern medicine council or the nursing council. And so that was an important issue that was there. I think another very big issue was attrition of the interface agency members that were working on ground, because with them leaving every 2 months, it was very difficult to build their capacity from the very start, right? And we sort of try to make this a sustainable system by making the whole team in a position where they can handhold the new people incoming in their team. But I think attrition played a very big was a big hurdle throughout the implementation process. But I think all of these issues have been a part of the implementation. But I believe the biggest challenge of microsite has been to the behavioral part of the professionals and the citizens, because the adoption of any system is also a matter of how you change your behavior towards that system, right? It's not only like many of the facilities have onboarded on the health management info HMI systems, but they're not using it. Not most of them are using it. So I think the biggest problem for us was to generate that trust among the professionals. And I think tapping on to the association's head and doing those induction sessions for them in every district, I think that was very crucial in bridging that, information gap that was there. Despite that, as the panel members rightly mentioned, that we had to change our communication strategy with every stakeholder. So, for example, we cannot pitch the same thing to an Ayush association as we pitch what we pitch to, say, modern medicine association, right? So, but I think that trust factor was greatly bridged by the induction session that we did. One major challenge in terms of behavior is still till this date is to change the behavior of the citizens towards these digital health systems, because most of us are very fearful about giving OTPs and giving your sensitive information. And I think this is just a start. I think it will take some time to build the knowledge base and capacity of the citizen itself, so that the demand is coming from their side. And I think unless that happens, we will have to work a lot on that part. I think that was also a major challenge, because we saw examples where uh, the citizens are not ready to share their information at the facility level. And that would not happen unless we make the awareness of those citizens very well. For example, there was a huge pushback to Aadhaar when it came, in the very start. But I think once people got to know that Aadhaar is a trustable, trustworthy, the registry, and it will help us connect with all sorts of schemes and all sorts of benefits, then they started using it. So I think citizen engagement is still persisting, the issue in that, but I think that also hurdled our implementation thing. Uh, Apart from these, I'm sure there are many other. I would love to hear from other panelists as well. But I think on a policy level, I think slow disbursement of digital health incentives for these private professionals has also been a big hurdle, because uh, for now, the only monetary benefit to the health professionals has been the DHIS incentive, and the slow disbursal in the at least the private sector part has you know has re- has you know has impended the trust that was, going for the private sector adoption. So I think on a policy level, we need to, fast track the DHIS dispersals. And yeah, so I think these few issues are the most prominent ones that I can think of. And I would also love to hear some of the issues that, Veda and Pallavi think or you think have been a part of the process.
Because Veda and Pallavi, if you would like to contribute to what Vikas has already said.
Yeah, so I completely agree with Vikas. And just to add on to it, is that ultimately what we are doing with the 100 Microsites project is laying down the blocks. We are building the system right now. The system did not come to us built for us to pitch to the professionals ahead. We are doing it right now. So obviously at an administrative level, at a policy level, at a behavioral level also, there are many gaps right now that we're trying to fill through this project. What needs to happen for it to become a well-oiled machinery is that every person has to, like Vikas said, has to have that behavioral change. Every person has to understand what the value that is ABDM that is bringing to them, and get involved. It has to become so, like the Aadhaar example is actually quite good, because Aadhaar was not mandatory, it was voluntary, but ultimately the process of the Aadhaar card became such a reliable source of identification that now everywhere you need KYC, you can put in your Aadhaar and it's fine. Everywhere you need some identification, you can give your Aadhaar and it's fine. So that is what we're trying to build here also. Ultimately, when we go to a hospital, I want to be able to just give my Aadhaar, and I should be able to give my consent. They should be able to fetch my records. So right now, the challenges that we see are actually our learnings for us to fill those gaps, so that the foundation that we build is strong enough, and eventually it becomes a streamlined process for everybody to rely on it. So that is my 2 cents on that.
Very rightly said, Veda. Thank you, Vikas and Veda, for your valuable insights on the challenges in the implementation of such a humongous project across the country. But I feel across all the challenges, one thing that good has come about is that at least people have started knowing and talking about ABDM and the digital health ecosystem and how they can start adopting it. Now coming back to the project operations. Now, since this is an adoption projects and the challenges needs to be identified, so as mentioned by Vikas and Veda as well, now those were the implementation challenges. But as we move across, as there are certain targets mentioned in the operation guidelines of the Microsoft project as well, so there must be some process challenges that might have come across in the due course of the operationalizing the projects. So what certain KPIs were monitored, or what key metrics were monitored to measure the success of this microsite, and what insights do they provide for shaping the future of ABDM strategies? I would like to ask this to Veda, like what were the KPIs and the key metrics for the project?
Right. Thanks, Saurav, for that question. It's a very interesting question. So, like I said, we are evolving as the project evolves. Of course, in the guidelines, to make sure that the project was implemented in a structured manner, there were targets set, and some metrics were given for us to implement it in a phase-wise manner, so that there was no chaotic, situation in any state. It didn't happen in a haphazard manner. So when the project began, we were trying to create an awareness about ABDM. We were trying to, first of all, get the private sector to get enrolled into the system, right? We were focusing on the registration. So at first, we were looking at professional and facility registrations. Those were our metrics for success. But eventually, when we had a substantial number of registrations, we moved on to how many of these facilities that have now registered, how many of them now have installed an HMIS solution in their facilities. how many have taken the demonstrations and actually, made the effort of digitizing their facility. Then HMIS aa gaya. Ab uske baad we're focusing on how many are actually using the HMIS, how many of them are actually using the softwares. So how many EHRs are getting generated. Now we have a good enough base. Now we have all the numbers that you mentioned earlier, 55,000 professionals, 50,000 facilities, over 50 lakh EHRs. So all of that groundwork has now been laid. Now what we look at, now when we look at success, what we see is, are we able to show that end-to-end adoption? When we think of the ecosystem, we are talking about, are the facilities talking to each other? Is a patient able to navigate through these facilities through the digital means that we envision, right? Within the context of a microsite. A microsite is a defined geography. So we went out with this vision that we're not trying to do it at a large scale, countrywide. हमने सब जगह शुरू कर दिया. That's not what we're doing. We are doing it in a smaller geography so that step by step we are able to build that ecosystem. Right now we're looking at interconnectedness. Right now we're looking at whether one software talks to the other, whether a patient is able to fetch and send, give consent for the records, etc. Eventually we will evolve to a different set of success metrics, which would be, are the newer stakeholders that come in, your insurers and your TPAs who come in, are they getting integrated well enough with this, other stakeholders? Eventually, what I see the final metric for success would be just the way that for payments, we reach out for our phones and we immediately, scan for a QR code and share through GPay, etc. A person goes to a hospital and immediately reaches out to their phone and asks for the record to be linked or shared, and etc. So the success metrics are evolving as we evolve with the project. You lay the foundation first, then you build on it, and ultimate goal is that ecosystem that we're talking about. So that is how the metrics have been changing.
Thank you, Veda, for explaining the key performing indicators for this project, as well as I think for the overall ABDM ecosystem. I think our audience might now have understood, will now be able to understood if when they look at a ABDM dashboard. Now, because you answered it in very depth that how we look at the process and translation of these KPIs, I think now they will also be able to understand where we are lagging or where we are doing very good in terms of adopting the digital health in India and overall ABDM. Thank you, Veda, for that. Coming to the point that this project was expanded and decided to be implemented pan-India based on the pilots done by PATH and WJCF in Mumbai and Gujarat. The feedback received and the strategic bottlenecks were identified, and this project was launched pan-India. So I would like to ask Vikas, based on the feedback and insights of this particular microsite project, how can this project now help to design a similar initiative in, let's say, some other limited geography for a pilot or a pan-India level project?
Right. So, Saurabh, I think we all have been discussing this idea of what do we take out of this whole project, whole funding that has gone into this private adoption. Of course, we have a large amount of information, and we have seen the gaps. We know the process and everything, but there's no right model so as to implement this private adoption of ABDM in any private healthcare ecosystem. But we definitely have learned many things from this process, and I think we can implement those when we move to a new geography or we want to scale it up. I think some of the again I'll share some of the things that that I believe have been very critical to private adoption that we can use it later. So I think to start with, I think we must do a mapping of facilities and professionals which are there in any district. Because so as to define the universe of who are we reaching out to and what are the and not only the number of facilities and the professionals, but also how are these facilities in terms of their digital infrastructure? Are they ready? Who are the ABDM already ABDM champions? Many of the professionals were already using ABDM systems when we reached out to them. So we need to start with analyzing the whole geography wherever we are trying to implement the adoption of ABDM. We need to know who are the champions, how many facilities are there, how are these facilities in terms of their digital infrastructure, uh, and so that we have a baseline to start with. Now, once we know that we have a champion, we have champions in the district, we need to leverage them in the very beginning so that they are able to have that networking effect in any geography, right? Because we identified champions and we established connection only towards the end of most of the microsites. But I believe microsite cannot be a private adoption cannot be a blanket process. We need to phase it in different parts. Like for the first part would be to make the awareness in the very first place, so that the still when we visit the private facilities in rural districts, we find that there is not much IEC done on the facility level, and that could that could be a starting point. We need to do information communication to all the private small facilities around the geography. We need to identify the champions in the very start and use them to affect influence other professionals, because it's again about the behavioral change, and that will only come from the champions, right? uh, in terms of the technicalities, I think we need to also focus on the digital prescriptions, and for that matter, I think many of the champions in our ecosystem are using digital prescriptions, because only when you make them realize the practical benefits of the using an ABDM system, then they will rely on the mission itself. uh, there is a facility in Sitapur that has been using Eka Care for a very long time, like before Microsite. And I think he has set an example for other doctors to use ABDM, and peer effect works in such scenarios. Uh, I think also I think the bottlenecks that we discussed, that hints us to also establish a communication between the councils, be more regular in communication with the councils, and that can happen only at the state government or the national level. And lastly, I think that takes me to the last part. We need to engage the associations more, so as to generate trust with the professionals, and that can happen only institutionally. When the association is on board, the idea of adopting ABDM, when they know and they trust the mission, I think their members will automatically trust the mission. So I think these are some of the things that we can take forward. But again, it's a long way, and we need to use all the information and the knowledge that we have gathered in the micro pilots to scale up the last thing that I forgot to mention is the importance of district authorities, government authorities at the district level, in leveraging their powers to influence the professionals. We know that the district chief medical officer already conducts various meetings with private health professionals at the district level. I think if we somehow integrate ABDM into the district ecosystem, the health ecosystem, it will be very easy to nudge and make that connection with the professionals at the district level. And when we do that, it will be easier for us to communicate. I think the communication is the key to any success of any program. So these are few takeaways from the current model of Microsite.
Vikas, I hope you were quite elaborate on it. I hope, based on the learnings and the bottlenecks that we have observed in this project, newer and more innovative initiatives with the targeted approaches will come. Coming towards the end and conclusion of this Charcha session, the last question is, since this project timeline is almost 9 months, what after that? What about the momentum that this project has built? I'm talking about the sustainability of the efforts that we all stakeholders have done for this project. So Pallavi, once the microsites are established and ultimately have achieved their intended targets, what should be the next strategic steps to maintain and expand and scale up this digital health adoption?
Yeah, Saurabh. So, as rightly mentioned by Veda again, that we built the foundation or we are building the foundation. We are in the process of that. So now it's time for more than 1 year into the program, and it is really for us to move from the registration part to the real usage part. Real usage by this I mean the transaction part. So basically, here I want to emphasize on the thing that we need to track the transaction, facility level transactions on a daily or the weekly basis. Some sort of mechanism need to be created or operationalized for that. So the transaction, how many health records are linked or created, as well as in the correct format. This also I want to emphasize here. We have some practices like some shortcuts we all develop. We are in the habit of developing shortcuts for getting things done quickly. So to drop that and to go into the proper e-prescription format, so that more standardization and other healthcare data standards will be implemented in this ecosystem that is necessary for data security and all those concerns that arise from time to time. Good quality linking, generation of the record, then linking of the records, and after that retrieval, or all those sort of transaction need to be done from the citizen side, and we need to create awareness for that. Another is active usage of, there is should be a mechanism to track. Now we have all three systems in place now. Initially we are driving with HMIS only. Then after some time there were LMIS, and some short layers or some softwares are also there that are kind of acting as a bridge. Now we have pharmacy solution also in place. So we need to track the transactions or the active usage of those solutions. So this is one activity that we regularly do, mostly in our UP microsites, because they have achieved good progress and some completed phase 6 also. So we try to track the facility level. We look into the transaction and make our or tailor our strategies as per that. Which facility is doing good and now they are declining, or why some are not doing. So we try to nudge them. If there is a strong resistance, we maybe step back a little bit, but if there is a willingness to adopt, maybe in the future, we try to soften our communication and keep on moving with these sort of thing. Another is I want to emphasis on that one-time training or one-time hand-holding capacity building is not sufficient, as this is with every software, every portal that we use. Once you start using any digital solution more or more, even for the habit, you discover new functionalities, new features on a daily basis. So I want to emphasize the role of refresher training, hand-holding, as well as for troubleshooting support that needs to be there for HMIS. Vendor providers active support needs to be there on ground. There is no declining from this fact. If it is not there, the system is eventually not going to work well, because there are several levers in this system that need to be working together in sync. Otherwise this mechanism will not work. As again Veda mentioned, that for this machinery to become a well-oiled mechanism, all the lever should work in jointly towards the success of this program. Another thing is the where we have facilities that are small facilities that are doing good. So try to leverage that for the peer adoption, and to capture more and more similar kind of facilities or similar kind of stream of, suppose if somewhere pediatric clinics are doing well, they are more open to adoption. So maybe target their peer group and try to onboard more and more facility specialty wise onboarding can be done for small facilities, labs or pharmacies. Suppose one chain of lab or one chain of pharmacies ready to adopt, so targeting those in the similar geography or maybe in another geography also. And also we try to, so as I mentioned previously, also large hospitals have their own system. They not might that this time they might not be so much interested in adopting ABDM. So small facilities we have. So there is a huge layer, huge chunk that is left behind, that are middle 50 to 100 bedded facilities, layered facilities. So there we can start piloting maybe here and there with those kind of facilities also. So this is in similar geography where our less than 10 bedded facilities are doing it, or maybe in newer facilities also with a fresh start. So both of these pilots can be done. Another thing is looking into the financial incentive. As I have also mentioned this previously in some of the discussions that we have right now, all the incentives are focused towards healthcare providers and the vendors, the software solution providers. So now almost more than 1 year, or maybe I can say 2 year into the microsite. We will be completing very shortly. Now it's a time to create the demand side thing we need to tap into. Some incentive, maybe smaller parts will go to the patient. Maybe it will not be a financial incentive, some kind of incentive that will help in improving the service delivery. Like Scan and Share is doing in not it is not part of microsite program, but it is helping patient in regulating the queues, or those kind of things need to be those kind of incentive that make the stressed out patient in the hospital his journey a little bit smoother, a bit more passionate. These kind of incentives and financial incentive, as Veda was mentioning, that UPI was a hit because there were several incentives in the start that were given to the citizens. So similar kind of incentives can be looked. Suppose subsidies or some kind of discounts when availing practices or from ABDM system, the clinics that are on HFR, or the doctors that are doing consultation and that are on HBR, or the prescription is e-prescription is generated from the ABDM compliant HMIS. So some kind of rebate system or discounts in the insurance, these kind of things can be explored from the citizens side of view. And one thing that I feel very strongly, that there is a time for look into the national level expansion strategy to bring more and more national level program on board and integrated with the ABDM ecosystem, so that so when we go to the field and we see several stakeholders that are there, we the verifiers or the ASHA worker and everyone, they have to do double administrative burden. So try to lessen it a little bit in implementation or integration of these programs into ABDM system, so that the patient data can be moved here and there without doing repetitive work. Or there in the initial, there is also whenever we are into a transformation or a that kind of a state, so initially there is a everyone feel that this is a lot of work for me. Now I have to do the older thing also, and now the newer thing. But this is only a phase wise thing, and we should be a little bit patient, and also to get this awareness into the ecosystem, also to have some patience initially to adopt a new system into your daily practices. May feel cumbersome or may feel like an extra burden to you, but it is a matter of time, and we have to maintain the legacy system also. So we cannot shut down the old system and just jump to the new one. So this transaction may take some time. Another 2 points that I want to emphasize is, so we are doing, NHA is doing recognition program. State is also doing for the facilities to do more and more programs for this. Also, NHA can do the recognition program. Currently, we did for doctors or facilities. We can do that. NHA can do that for states as well. So we have several programs like Kayakalp and all those programs where state are getting awards and incentives for doing some good work, and they brought on the national platform some financial incentives are also associated with that. Those kind of things can also explore for state to become a little more competitive among themselves to adopt the system. And last thing is, I cannot emphasize more and more to increase more and more awareness and the digital literacy by whatever means we can do. Some NHA can also take initiative and do more capacity building or awareness increasing kind of. So recently there is a very big conclave in Bihar. So similar kind of conclave where two events are done in the Bihar. So one is all the JDs are invited, and in another all the stakeholders, some HMS vendors, some practitioners, some champions are already there. So these kind of programs can be done to open a common platform for dialogue and sharing of the best practices. These kind of things we can explore one by one.
Thanks, Pallavi, for your elaborated and valuable inputs on maintaining the sustainability of this project and the efforts that we all stakeholders have put in. Well, this has been an insightful discussion for all of us. And I'd like to again thank our panelists for sharing their valuable experiences. To conclude, I think the 100 Microsite project is a key milestone in India's digital health journey, and the lessons learned here will be crucial for shaping futures of various initiatives under ABDM and digital health landscape in India. We have had a great discussion so far, and now I'd like to open floor to the audience for asking their questions. If you have any questions for our panelists, please drop them in the chat, and we'll try to take them one by one. And over to you, Pallavi, here on. Thank you.
Thank you so much to all our panelists and to Saurabh for facilitating this so beautifully. It was a very, very insightful session, and we kept having plethora of questions. Saurabh, I've sent you a bunch of questions that we've received from our audience. Since we are already we've overshot on time, maybe we can take one of those questions, and yeah. We can maybe try having the rest of the questions answered by panelists, and we can send it all to you.
Raj has asked one question. How can we become field agency for a state in India? He has not directed this to any one of the panelists, I think.
So, Saurabh, maybe I can share a question with you that we received. So, yeah. So how should patients trust the ABDM data privacy if data is stored by a private HMIS provider? I think this is a question which any of our partners can maybe answer.
So I can take it if that's fine.
Yeah.
So like we mentioned, I think multiple times throughout this session is that HMIS providers do not store your data. NHA does not store your data. Your state government does not store your data. Neither does your professional, the person that you go to. The only data that your professional will have is the data that they generate. So throughout the privacy by design concept that ABDM runs by, it ensures that your data is end-to-end encrypted. You are the owner as a citizen, as a patient, you are the owner of your data. Nobody can see that data without your consent. The DPDP Act makes sure of that. And this is actually somebody else also in the Q&A section had shared a similar question. What is the major concern? So this is the major concern that from the patients and professionals alike we have seen. And this is the answer that we give them also to make them feel a little relieved about. Also, this is a very important question, of course. In the digital age, everybody is afraid of their data getting leaked, but that is the data by the privacy by design concept ensures that that does not happen.
Vikas or Dr. Pallavi, would you like to add anything?
No, I guess I totally agree with Veda that it is for us to understand and create a little bit more awareness on this thing that this is a decentralized system and nobody is storing anything. So whoever the decentralized system itself means that whoever has the ownership of the data that have their data, or anyway, doctor always have your data when they write the prescription in paper form in their own system. So also the data is already shared with the consent of the patient, and you can all the time revoke the consent or cancel the consent or fix the time. All those sort of mechanism are also, already there.
So I just wanted to say that we are already using private systems all across in our lives. So, and whenever government partners with any private gets into a private ecosystem, it makes it more safe. So I would just say use the systems which are ABDM compliant, because government is already taking care of your privacy, and that is why all these initiatives are happening. So ABDM compliant systems are more, you could say they are more you're safer than those which are not compliant with ABDM. So that's the only advice I would.
Wonderful. Thank you so much. For the rest of the questions, we have a discussion forum that is live on the Yodh app as well as on the website. So we'll perhaps get our experts to answer the rest of the questions over there so you guys can take a look, have all your questions answered. Once again, Veda, Vikas, and Dr. Pallavi, thank you so much for sharing your knowledge and your expertise, and Saurabh for facilitating this for us. And most importantly, to our audience for joining the webinar today. Do stay connected with the upcoming Yodh events and be a part of this global network. Thank you so much.
Thanks a lot.
Thanks, everyone.
Thank you, everyone.
Thank you. Thank you.
Thank you.